seem to have a full spread, including general practice, hospital and community and mental health specialities. Okay, fine. So let's start with what we're going to try and do today. So you will hear in the news, in the papers, that the budgets are tight, the NHS is struggling, finances are a problem, and you'll see all these headlines. But this is not a new problem. So these headlines have been from the last 10, 20, 30 years. They regularly occur. So problems and financial issues in the NHS are not new. But particularly the last couple of years, it's felt even tighter. And there's been even more emphasis on trying to kind of balance the books. I'm going to try and address some of those, why that might be, why that's an issue, and why we're historically, when the money's been tight, a lot of us in the front, kind of in the day-to-day, haven't really felt it, but more recently we're starting to feel it, and why that is. Okay. So the purpose of today is to help you navigate the health system. It is not about making you accountants. It is helping you understand the processes behind everything. We want you to make you clinically driven, because I'm a clinician. My first and foremost priority will always be the safety and the quality of care that I give to my patients, but aware of the financial consequences of the decisions you make. And then why, from a selfish point of view, why is it? What do you want to get out of it? Okay, so what we're hoping to achieve is that you understand how money flows into and through the NHS. We're going to, towards the end of the day, try and focus, or more in the morning, try and focus on how we then develop those business cases. We all have ideas for improvements within our specialities, within our departments and areas, and we can do the QI bit, and try and do a small change. But to do the bigger changes, to get the funding to employ more people, or to create more jobs, or to change the pathways, they often say do a business case. What does that actually mean? What do we actually need to do? Okay. And the final thing is more a kind of a broader picture of the importance of financial stability and sustainability within the NHS, and why that's important. So that's what we're going to try and do. I'm going to try and do this in a kind of structured approach. So we're going to try and go through the NHS structure, how the services that we deliver are paid for, a little about costing and patient level costs, a bit about costing and patient level systems. And finally, to try and round it all up, we're going to talk about business cases. Feel free to ask any questions in the chat, or put your hand up. As I said, you'll get the slides later. There'll also be links to the animations that we have in here. Okay. So, and this is not, I'm not going to ask you to put anything in the chat, but this concept of value in healthcare. Okay, so that's what we're trying to achieve. We're trying to achieve the best possible value that we can do. So we're in a finite health system. Can you see slides, or you can see a seal?
A seal.
Okay, let me try again. That better? Okay, so
yeah.
Let me just go back a couple of slides then. So so money flows, QI projects as business cases, financial stability, NHS structure, how services are paid for, clicks, and business cases. They're the things we're going to kind of address. So value in healthcare. So what does that mean? you'll hear it, value-based healthcare. You'll hear that in a finite system where the where we can't do everything that we want to do, how do we make sure we deliver the best value that we can? So 3 types of value. Okay, and this is from the Oxford Centre for Value, essentially, and they've defined it as something called allocative value, which is how we divide up the resources that we have. So that can be at national level, that can be at ICB level, that can be within your organisation. So they get their resources and how they divide them up. Okay, it's also called economic value. And then there's concept of technical value, and this is what we're going to focus on. Because for most of us who don't make those decisions at national, ICB, or organizational level, this is about making the most of whatever we've been given. So we've been allocated the resources. How do we deliver that value? Okay. And this is where your business cases and your QI projects all have to try and do, is deliver technical value, also called efficient. And the final one is a non-financial value. It's about personalized value. And it is about it's related to how you, me, our patients all value different things and have different priorities. And I see it in my clinics. So I do high risk clinics, and you get patients that who are relatively well, coming for quite big surgery, and on paper in the numbers they don't look they're going to be that high risk, but the impact on their life, they don't want to take that risk, because they value. So I had a patient who was in their 80s, relatively minor surgery. Well, I say it's a hemicolectomy, so not minor surgery, but in the grand scheme of things, not that complicated. His numbers weren't that high, risk factors weren't that big, but I said to him he may not be able to walk his dogs, and that was what he wanted, and that's what he prioritized. I've had other people who are much more high risk, who the thought of cancer means that they want an operation and don't care about the risks and the outcomes. So that's from a personal experience. There's the Virginia Mason Institute, which is an American organization that really kind of really plugged value-based healthcare, and they did some work with a health board in Wales, and they looked at a neurology clinic. And they asked patients what their priorities were. They asked the clinicians what their priorities were, and the clinicians wanted to diagnose, diagnose the issue, prevent disease progression, and treat the patient's symptoms, which is further down the list. Whereas the patients, their priorities were more sleep, more energy, be able to do things day to day. So it is just an example that value can mean different things to different people. That's called effective value. Right. So this is a finance talk to some extent, so we're going to make this into an equation. So we're talking about technical value. So what one word would go on the top line, and what one word would go on the bottom line when you're defining value? So we're going to have a few of these kind of interactivities just to stop you having to listen to my voice the whole time.
Cost
So what
on the
one
bottom?
word would be on the top line, what one word would be in the bottom line? Okay, so we've got cost as a consistent metric on the bottom line. Okay, so that's fine. What one word would be the best way of defining the top line? So some people put outcome. So outcome is, if you look at some textbooks and things like that, they state outcome as a good definition of value. There is a better word that encompasses more than just outcomes. impact. Okay. We've had a few people say benefit. So the word is quality. Okay, so value is quality over cost. So the next part is, what are the three domains of quality? So if you look at your organization's quality commitment or quality strategy, or in the NHS plans, or in where else? It's in the NHS legislation, the constitution. There's three components of quality. It has been asked as in an interview before, so consultant interviews before. So what are the three components of quality? I'll give you the first one. Clinical outcomes. Okay. And I'm going to talk about clinical outcomes while you think of the other two. So clinical outcomes can be, there's no specific clinical outcome that you need to use when you're defining value. So when you're doing your QI project, your business cases, clinical outcome, there isn't a specific one. It doesn't, it doesn't have to be patient-related outcome measures. It doesn't have to be mortality. It doesn't have to be length of stay, complications rates, and there's no time limit to it. Because if you look at the standard metrics, you may not find the measure that you need. So one of my my colorectal surgical colleagues. So I will say that most of my examples are either surgical or hospital based, at least, because that's the experience that I've had. So they close a laparotomy wound a slightly different way. They take an extra half an hour. So that's not great for productivity. It doesn't affect pain. It doesn't affect length of stay. It doesn't affect complication rate in the first, I don't know, 30 days, which is what everyone worries about. So under the standard metrics that we'd use to measure outcome, it wouldn't have achieved anything apart from making me stay an extra half an hour in theatre. But what it does do is significantly, so more than 50%, reduce the risk or incidence of incisional hernias. Now, incisional hernias are big operation. If you have to repair an incisional hernia, it's a big operation. It's not a small, like an inguinal hernia or other type of hernia, standard hernia repair. So incisional hernias tend to be quite complex. So by doing that, but this is not at 30 days, this is at 5 and 10 years. So if you use the standard metrics to define your clinical outcome, you wouldn't have picked it up and it wouldn't have shown any benefit. So it's just a way of demonstrating that choose the outcome measure that best suits what you're trying to show. Okay, and I think overall somebody has put the two next to, which is patient experience or patient satisfaction and patient safety. Okay. Now I've had people say, what about staff morale? But they directly impact those three top domains. Okay, so staffing level, staff morale, staff experiences all impact the patient experience, patient safety, and clinical outcomes. So when you do your QI projects or your business cases, you need to show that there's an improvement in at least one and preferably multiple of those domains. Okay. So cost. Cost can be split into two areas. There's your revenue costs, which are your day-to-day running costs. They're kind of recurring, ongoing costs. And your capital costs, which are your big one-off purchases. They don't have to be big, but they're one-off purchases. They're for buying things generally. So most budgets are split into capital and revenue. Okay. And that's important for when you're looking at your business cases as well. Capital and revenue. Okay. So the purpose and the reason I'm showing you this equation is that there's twofold. Okay. One, when you put your business case in, you have to show that the improvement in quality is worth the cost. Now, we could rebuild every hospital in England, and in some cases, like in Leicester, it would be a massive improvement, and you would get an improvement in quality that would justify the cost. But in others, it may not. Okay, so a small improvement in quality may not justify a big expense, and that's what they're trying to weigh up when you're judging or assessing your business cases. The other issue is that this guy, Michael Porter, who's a Harvard business professor, when he came up with a version of this equation anyway, he said that essentially if you improve quality, you will reduce costs. The problem is, and it's a big thing, we try and move away from it, but we're stuck with it, is that it may not be the cost to your department. It may not be the cost to your organization that improvement in quality benefits. It may be societal benefits. Smoking, stopping smoking generally doesn't have direct implications on healthcare to us, but it might have broader societal benefits. It might have longer term outcome benefits. Okay, so there may be societal and environmental economic benefits to an improvement in quality that is not captured directly by in the kind of the standard revenue costs and capital costs. There was a period of time where we really factored that in. We started to take that on board when particularly in a few years post the pandemic, we started to get better at that. But in the last 12 months, and probably for the next 12 months at least, we're back into our silos, and it's about what our department does rather than what the broader health economy does, which is a bit sad. But we need to move away from thinking of ourselves in isolation. Right. Any questions on that before we move slightly on to NHS structure? I'll keep going. If you have anything, I'll return to them in a second. So the NHS was born 1948. It is continuing to evolve. It's not been static. It was never a planned process. So when the NHS was created, it was basically nationalisation of various existing structures. And so in year one, they went over budget. So in its entire history, we've always struggled with financial issues. They've just become more acute, or a bigger problem, essentially. And it's evolved. So in 1962, you had this hospital plan where they tried to be a bit more organised. So after the baby boom, after the Second World War, they realised that there probably needs a bit more planning involved in healthcare. So they started to build hospitals, or DGHs, for every 125,000 population. They started, and quite quickly they ran out of money. So there's a recurring theme across this. And to try and coordinate it even better, they developed health authorities in 1974. And then the issue in 1990 was they introduced this concept of an internal market. Now, an internal market is where health care organizations essentially compete with each other for services. So you had a situation where, in Leicester, we had our urgent care centre, which was literally on our main hospital site, but not directly we didn't run it. It was run by, Nuneaton, which is, another George Eliot, which is another hospital, 30, 40 miles down the road. We've had Derbyshire Community Services running some of our peripheral hospitals. So the competition means that you get a little bit more, less coordination, and they had different systems, they had different logins. The idea of the internal market was that it would improve quality while driving down cost. It's that capitalist kind of concept of notion of improving quality and reducing cost by allowing organizations to compete. And for a while, it probably worked. But that was a period of boom where the economy was doing well, everything was quite rosy, and it worked for a little bit. But when there was not bust, but there was economic downturns, then you ended up going for the lowest price, and quality suffers. And that's something that we've kind of, it's kind of gone in cycles over the last 35 years or so, where competitions come in and out of the NHS. In 2000, there was obviously just shortly before that, there was a change of government, and they introduced this NHS plan, which whose prime objective was to reduce waiting lists. So they introduced this concept. They introduced all 4-hour targets. They introduced big incentives to drive down waiting lists, and again, that worked to an extent. It was very successful what it was intended to do, but it had unintended consequences in that it made emergency care basically lose money. So any hospital that had emergency component to its services that it offered basically struggled. And the specialist hospitals and a lot of the other areas that did primarily elective work did well. Also created a huge boom in the private sector because waiting list initiatives were paid quite well. The last major reforms were in 2012. I've called them land reforms after the health secretary at the time, only because the names of this reform, the Health and Care Act and Health and Social Care Act, are very similar. But the last ones in 2012 created this, created CCGs, created NHS England, and again, with a lot of these things, a lot of these ideas and processes, the concept, the principles behind them probably are sound, but it's the implementation and how long it takes to implement them that meant that the world had changed from when it was conceived to when it was implemented. So whilst it was only implemented in 2012, it'd been conceived many years earlier, and between conception and implementation we had the financial crisis, which changed the economic landscape. And so the idea was that you get local decision making about local priorities given to the people that were most local, so the GPs, and they then decided how best the service should be run in their areas. Okay, so again, the idea seems reasonably sound. The problem was there was too many of them. So there were 210 of CCGs when they first started. And quite quickly, they realized that actually didn't give you any scale to make decisions and commission services, because a hospital, we couldn't, if only one CCG commissions our service, we can't run, because actually our area covers 10, 20 CCGs. So in the end, what they ended up doing was collaborating, and so one would be a lead CCG for the other 20 for one service, and so they shared out the paperwork, and then eventually started merging. And so by the time they were abolished in 2022, 2023, they went from 210 to about 111, and they probably would have shrunken even further had it not been for the fact that they were abolished. The other thing that they put into the law was this concept of competition. So the CCGs had to put out to tender every service, again, because the idea was that they wanted to improve quality and reduce cost. As said, there was the economic crisis, which meant that they really struggled, and a lot of the private services private sector companies that took on those services realized that they couldn't deliver based on the payment systems that were there. The most famous one was Circle in Huntingdon, where they Hitchinbrook, anyway, somewhere between here and Cambridge, Midlands. The Circle Hospital tried to run it, and they realised that they couldn't run it any further because it wasn't making the money, and they had to make money in order for them to survive. They were losing money, and private companies can't lose money really. So they gave it up and got out of the contract, and was had to be taken over by the NHS. And then the Health and Care Act in 2022 wasn't that big a change. It was tidying up the legislation that so that between 2012 and 2022, the NHS tried to move away from competition because they realised it wasn't working. They tried to move towards collaboration, but they were limited to some extent by the legal framework. And so the main purpose of the 2022 Health and Care Act was to tidy up that framework, remove the idea of a competition, um, and encourage collaboration. That's basically what's happened. So the how much money we get as into the health service is determined by Parliament, and specifically the Chancellor and the Treasury. It's determined every few years by the spending review and then adjusted by the budget report. So we talk about increases in spending. So this was a diagram produced by the King's Fund. It suggests that realistically, in order to maintain our services, so not improve them necessarily, but maintain them and maybe improve slowly, we need about 3 to 4% increases in real terms increases. So if once you've taken out inflation, you need increases total health spending in England. So health is a devolved concept. It's a devolved entity. So Wales, Scotland, and Northern Ireland, they determine their own health spending based on the income they get, but also based on various formulas that allocate the money to them. And we rarely got between 5 and 6, and certainly unusually get 7% increases in our value, in our income. So if you look at how things have changed now, this goes up to 2024, 2025. We've averaged somewhere between 3.6 and 3.8% increases. So we've stayed within that, but it's not been consistent. It's been very much up and down for the last 20 something years, with the worst probably being the 1.1% during the austerity years. And between 2 and 3% is basically where you're in that kind of no man's land of just trying to keep things going, and that's what we are at. We are in this no man's land. So the current spending review has maintained about 2.8% increase. So that's again about static. But the problem is, if we want to increase the spending on health, where does the money come from? So spending on health already, as a percentage of day-to-day public service spending, okay, is very close to 50% of all public service spending. So there are only a few ways of increasing that. We can either cut budgets of other services. Now, we've probably done that quite a lot already. So a lot of other social care, council, local authority money, lots of other areas have already been cut significantly. You can improve the economy, so make that 43% worth more. You can borrow money, or you can increase taxes. So if we need to do, and that's a political decision, and it depends on what your outlooks are, and different political parties have different ideas on that. There isn't a right answer. There's just which one were you going to choose to do that. But we can't just increase it like that. We have to have a mechanism by which you want to increase that money. Okay. So if you would put in order the budgets of the Department of Health and Social Care, Department of Education, and Department of Defence, how would you rank them? So quite a big. I'm talking about, so what we're talking about is the actual budgets. So every year the budgets get set for the financial year. So I'm talking about right now what the current budgets are for health, education, and defence. So for 25-26, so that was just finished. Okay, we spent, this is billions of pounds, so with a B, billions of pounds, 215 billion pounds on health. So, and I say health because whilst it's called the Department of Health and Social Care is funded separately by the local authorities, and this is only in England. So 215 billion pounds for health spending in England. Okay, 100 billion to education, and you can kind of see why we've got only one aircraft carrier and a handful of boats available, because our budgets for the defence, our Ministry of Defence is only a mere 62 billion pounds. So things like the Trident or aircraft carriers are paid over 20-30 years. So that's why, whilst they are billions of pounds each, that cost is spread over billions of tens of years. Okay, so that's why we can afford those kind of things, and it's why building anything takes so long, because the costs are so high and the budgets are relatively small. So even with recent increases to commitments to increase defence spending, it might increase by another 5-10 billion, but it's going to nowhere near education or health spending. Yeah. So we have very little wiggle room. Okay, so where does that money go? So currently, and I say currently because obviously some of this is going to change in the next year, but this is how the budgets are split. The little blue bit is what the Department of Health and Social Care kind of spends on itself, and its kind of functions, which I'll talk to you in a minute about. The majority of the money goes to NHS England. Once NHS England is abolished, the majority of money will go to ICB. So it still goes to the provider organisations, essentially. So the majority of the money will go to provider organisations for their day-to-day running costs. Now, you'll see different measures for health spending. Okay, and it depends on what you include and what you don't include. This is something called the departmental expenditure limits, which is basically your max budget. So it's set every year, and it gives you your capped budget, which the department have to kind of stay within. Now there are fiddles around it, but this is the easiest available data that you can get. So you can see that the NHS England budget continue increases, okay, because that has to rise, because that's where our provider services go. Capital budget goes up and then comes down again. That's your big spending. And in fact, your Department of Health and Social Care budget basically shrinks. Again, this is in billions of pounds. So why are things more difficult this year and this year, next year, last year? Essentially, for probably about 10 years now, probably a bit longer than that, every time we've overspent on the orange, which we do every year, we have to use money from somewhere else to plug that gap, because that whole bar is how much money we get. So we have to plug it from somewhere else. And what we've been doing is taking money out of the grey bit, the capital budgets, the budgets for rebuilding hospitals, for maintaining stuff, and buying new CT scanners and this, that, and the other. Okay, so our capital budgets have been basically raided to cover our overspending on our day-to-day, which is why the new hospitals program is being delayed, which is why and any money that has been there has had to go to priority, because there's so little. It has to go to priority projects. So when the company that was building the Midlands Metropolitan Hospital in Birmingham, or in the West Midlands, and the new Liverpool hospitals went bust, that became the priority, because actually it was costing millions of pounds just to keep the site viable. So it meant, so then you've taken the priority projects, all the cladding projects, you have very little left for everybody else to do their building work. So that's why they are trying to stop that. They realise that actually our infrastructure is really bad, and we need to spend some money on infrastructure. So they're trying to tighten it up on our day-to-day spending. Okay, so that's why it feels harder, because we are trying to protect that grey bit so that we can actually build and improve our infrastructure. Okay, so we talked about the blue bit. The blue bit funds, let's say 11 different organizations are funded by that blue bit. How many can we name? Yeah, so they bid for capital money. So it depends on how much money you want, essentially. If it's less than $1 million, you can probably get it within. You can probably spend it, and you get a capital allocation of a certain amount, and you can spend that how you want. If you're a foundation trust, and we'll talk about that in a bit, you have a bit more leeway, but which they're trying to remove. And otherwise, essentially, for bigger buildings, you've got to apply for that money. The last round of funding, they basically had like £4 billion to give out, and they had like £15 billion worth of applications. So there was a shortage. Okay. I'll talk about the ICBs as providers in a second, a bit later. So CQC, yes. NIHR indirectly, so not really. It gets its funding from other sources rather than from the Department of Health and Social Care. Yeah, okay. So Health Education England, no, it doesn't exist anymore. Well, and neither does Public Health England. Well, it does, but under a different name. NICE, yes. UK HSA, yes. The GMC as a regulator is funded from Parliament, as is the Nursing Midwifery Council and the one for the allied health care professionals. There's some work going on to see if they can reduce the number of regulators, but that's funded through Parliament separately, not through Department of Health. So these are how they're categorized officially, but don't worry about that. Executive agencies are essentially almost part of the Department of Health and Social Care. They are kind of, they have no, they're completely under their control. So you have the Medicines and Healthcare Products Regulatory Agency, which approve drugs and products and devices. They're most famed for being the first regulatory organisation that approved the COVID vaccine. The UK Health Security Agency, which is formerly known as Public Health England. So when it was Public Health England, it only had an English remit. UK Health Security Agency has a much wider UK-wide remit. So some of these have remits that are specifically to England. Some of them have national remits across the whole of Great Britain. So those both have UK-wide remits. The NHS Blood and Transplant. You've got the Business Services Authority, which basically looks after prescription charges on our pensions, most importantly. You've got NHS Resolution, which basically is the new name for the, well, not so new name, for the Litigation Authority. So they deal with public patient safety. They administer the insurance scheme, which is basically called the Clinical Negligence Scheme for Trusts. And you have probably one of the smaller organisations, which is called the Counter Fraud Authority, which its name gives it away as well. So you have your commissioners. So currently, NHS England, but again, that's being abolished probably by next year, but it's not really fully committed to that yet. You've got NICE, which is the National Institute of Health and Care Excellence. NICE has existed for a long time, but what it stands for, as in the actual acronym, has changed a few times. So Health and Education England and NHS Digital were absorbed into NHS England a couple of years ago, 2-3 years ago. They for two reasons: one, to give a more coordinated approach; two, to protect their budgets. Because when any politician, any government say they're going to protect the budget of the NHS, they mean that orange bit. They mean the budget of NHS England. And what ends up happening is that the Department of Health and Social Care's budget gets cut. And so for many years, Health Education England's budgets were just continually cut. You ended up with a situation where it wasn't doing very much because funding was so small. So to protect the remaining funding, they absorbed it into NHS England. Then you got your regulators. So some are quite well known, CQC, and then you got your niche ones. You've got your Human Fertilization and Embryology Authority, Human Tissue Authority, Health Research Authority, and then the kind of the newest one, which is the equivalent of the airplane safety one, which is the Health Services Safety Investigations Body. And that looks into trends and patient safety things, but in a no blame culture. So yeah, the GMC annual fees go to fund that, but GMC is actually, because it runs the kind of the tribunals and all the exams and all that kind of stuff. It has income, but it gets some money to make sure it's regulated by Parliament. I wouldn't say that's the bulk of its money. I think the PLAB exams and the GMC annual fees probably fund most of its activities. But it probably does more than we realise. Okay. Any questions on that? So the majority of the money from NHS England currently goes to integrated care systems. There's a question up here about how ICBs are organised as provider organisations. That is still very much in the works. So when NHS England is abolished, which will happen next year, I'm going to mix this for a second. There's currently 42 ICBs. There's going to be likely to be about 26 or 27. I think we're still not sure on one of them as to how many mergers are going to be. And so they're going to take on a lot of the responsibility for commissioning that NHS England had. Okay. So and there'll be a few really specialist areas that the Department of Health and Social Care will do. So basically, that's going to split the responsibilities. I'm going to show you this video. It is 3 years old now, so then we'll go through some of the changes, but the concepts and principles are the same, though, and the proportions are probably roughly the same in terms of where the money goes, but the actual numbers will have changed. I might even stop it a little bit early because some of the stuff at the end is completely irrelevant now.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years, to create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Okay, so some of that, obviously, I wrote because we got the first part is basically similar to my presentation, and the last bit was the bit that I didn't write because it was done by NHS England. So the system control total is basically, or share control total, basically means that within a patch, an ICB patch, what tended to happen was one organisation would make money or be above their total expenditure, and one would be below it, and there was no real collaboration between them to do that. A shared control total means that the system as a whole had to achieve whatever they said they were achieving. So increasingly at the moment, it's not about whether you make money or lose money per se. It's about whether you can plan what you predict what you're going to be doing. So, for example, if last year you as an ICB lost £10 million, the plan would be to be negative £5 million this year, because to try and say you have to be break even this year or make a profit is unreasonable. In some cases, even asking for a £5 million saving is pretty difficult. So a share control total means that as a system, that's what you're aiming for. Okay, and most of the time, the ICBs have to break even. That's basically what it is. Individual organisations within that have to try and mitigate that, but within reason. And that's what a system funding envelope is as well. It just means that the ICB gets the budget and then decides how it's split, rather than it being allocated to provider organisations. Commissioning, for change of commission from national commission to local commissioning. I think there's also already probably a lot of postcode lottery type thing in commissioning. The idea being that these are the ICB's responsibility, and because there's going to be only 26 of them, their responsibility will be to make sure that their patient population has access to all these specialised services. So you have to commission from somewhere. There will be some, I think there's going to be about 60 or 70 services that are going to still be commissioned nationally, because they are so specialist that there's going to be one or two centres in the country, and so they have to be super specialist and commissioned nationally. The regional commissioning will, in theory, actually reduce the amount of postcode lottery, because even at the moment, even within our, what is currently a patch. So we have, South Leicestershire, North, they'll have different guidelines for what they will fund, in terms of, for simple things, the most controversial one, the one with most variability tends to be things like fertility treatments. So the idea would be, in theory at least, and I have no, input into this, that they might actually decrease that postcode lottery or variability at least. The Department of Health and Social Care, Department of Health, will still operate, we believe, 7 regional teams. And so the current NHS workforce component team will still exist. It'll just be badged Department of Health workforce team. And that's what HE will be. The likelihood is that most of TPDs, heads of school, will remain. They'll just work for Department of Health. They may or may not get any more admin support. They have got very little at the moment, if you talk to any of your TPDs and heads of schools. So the idea, hopefully, is that it will improve that. Why the aim? So ICBs are essentially the healthcare component. So they actually manage the healthcare system. Okay, so because they include the community acute mental health, ambulance, primary care networks, and local authorities. Okay, so they manage the healthcare system. The ICPs are supposed to bridge that gap with the social care system. So by involving housing associations, charities, independent sectors, the police, the idea is that you try and help bridge that gap. Now, in different parts of the country, it's working to different extents because the components and the interested parties have changed and are not fixed, unlike the ICBs. It's very variable. I don't think they've fully matured, but then I don't think the ICBs have still got to grips with things. Generally, no. So the ICPs don't generally commission things directly. They have statutory kind of status, but they're in that they have to exist. But I don't believe they commission anything directly. The health system commissions the ICBs. ICBs commission any health services. Any non-health services are normally done by the local authorities because that's where the funding comes from. The ICPs don't have a budget. So often it is like drugs and alcohol charities, shelter, homeless charities in that area, the police, any big housing associations. So sometimes there's people who provide sheltered housing or housing associations that run areas. If there's specific care groups, there's certain parts of the country have like most of their services delivered by a particular company in terms of their social care, so they might be asked to be on the ICP. So generally, it's interested parties who have a stake or an investment in the health and social care of the population of that area's population. That tends to be who are on those boards. So yeah, it tends to be like the chief executive of the housing association, the representative of the drugs and alcohol charity, things like that. Okay, so as I said earlier, the key thing with the statutory bodies, they're both statutory bodies. They remove that duty to compete, that obligation. So it doesn't mean you can't put things out to tender. You just don't have to. So they will still put services out to tender if they feel it's in the best interests, but they don't have to. And they have a duty to collaborate, and they're allowed joint appointments committees, which weren't officially allowed because of competition rules before. Okay. The other thing that 22 legislation did is basically give a lot more power and responsibility to the Secretary of State for Social Care. So West Streeting currently has much more oversight of Department of Health and Social Care than previous. So people around Matt Hancock's time and before Jeremy Hunt's time. So at that time, the chief exec of the NHS England was the kind of the person that led it, and he got some direction from government, but it wasn't absolute control. Whereas currently, in the new system, the Secretary of State for Health and Social Care has much more control and say. So we talked about the mergers. I said spending review for 2025, which is the last big spending review, to 2.8 real terms increase in total health spending. The idea was that capital investment will gradually increase and technology funding doubles to 10 billion by 2028-29. That's the idea. They had the 10-year plan, which had 3 areas of focus: community, hospital to community, sickness prevention, analog to digital. And they had these 5 objectives. The key component that was missing was the implementation plan. So this is all about the ideas, but they are the same as every plan has had for the last probably 20 years. We've always wanted to from being reactive to proactive. We've wanted to shift people out of hospitals because hospitals are expensive. And yes, we've always wanted to be more digital. So they're not anything new. The key thing that was missing in this was the last chapter, which is how they're actually going to deliver it. because I don't think any government has had anything different to those 5 objectives. We talked about cutting waiting times, we talked about primary care before, improving operating model. That's a very vague term, doesn't really mean much. And I don't want to go down the efficiency productivity route because that's a whole different talk. So they're going to abolish NHS England. We believe it's going to be done next year, but with the current climate, it may be delayed. We'll find out in the King's speech later on today if it's going to be officially done, because you need an act of parliament to do it, so they have to put it through that. Realistically, the powers will be split between the 26 remaining ICBs and Department of Health and Social Care. So any questions on that? So ICB's been providing organisations. So those ICBs are working well to different extents. So some ICBs are very collaborative. They all the organisations within it are working together, particularly where there's fewer of them. So if you've got a community and mental health trust, you've only got a couple of primary care networks, or there's fewer people involved, then they tend to work better. And particularly if there's the local authorities are similar. So if you've got one local authority in your area, it tends to work better as well. And so those areas that are working very well and at advanced level of collaboration are being considered to be basically merging all the organizations within them to be a provider organization themselves. So the ICB basically becomes what in America is called an accountable care system organization, but essentially one organization manages everything. And it then becomes very similar to the health boards, which they have in England, Scotland, Wales, and Northern Ireland. So it's not a completely new thing. It is just how it's going to be implemented, and we don't really know. They haven't really given much more detail on that. And they're focusing on getting rid of NHS England first, and then they'll do the next bit after that. But because everything takes a long time, they have to what they tend to do is put something out there, and they look for feedback and then decide how it's going to evolve after that. Yes, the ICB people are paid, but a lot of them. So lots of the people on the ICB already have jobs. So they, the chief executive of my hospital is on the board of the ICB. So they have their own roles, but there will be separate. There'll be a separate medical director for the ICB. There'll be a separate chief executive of the ICB and finance director, and they will be paid. And they'll be paid at. There is a salary banding for those. They're called very senior managers, and they are very well paid, but they have to take on that responsibility. So yes, it's done on national pay scales. They don't get to determine their own pay. So payment systems. Okay, so this is about this is the final section before we have a bit of a break. This is about how we get paid for the services that we provide. Okay, and it changes. This is the thing that changes the most in the NHS generally, and sometimes it's subtle changes, sometimes it's big changes. There are 7 building blocks. I say building blocks because if you put together any combination of these building blocks, you can basically build any payment system that's used anywhere in the world for healthcare spending. So we're going to go through the building blocks, tell you what they are used for, and then essentially they put different combinations of them together to create a payment system. First one, it's called a block contract. So that's a fixed amount. So you can negotiate what that fixed amount is based on your costs or previous contracts or what it is you're going to be delivering, but it's a fixed amount. Okay, so it's a lump sum to pay a specific range of services. The key thing is, once it's been decided, it doesn't actually matter what you deliver. So if you are on a block contract, whether whilst it will be based on delivering 100 appointments. If you deliver 90, you don't get penalised. If you deliver 110, you won't get any extra money. Okay, so it's useful because you know how much you're getting. Your commissioners know how much they're spending, so it's predictable. It's generally used for things that are hard to measure, or where there's it's difficult to know what your delivery is going to be. So it is used for community services. It is used just generally for things like mental health at the moment. In the post-pandemic period where we didn't really know how much activity we were going to be doing, it was used for everything. There was a period pre-pandemic where it was used in some areas for most things because it was predictable. Where when you're a clinician, you tend to know when there's when you're on a block contract that you do, for example, in winters where we're on a block contract, you don't get the pressure to do elective work. If your emergency list is overrunning and it's being overwhelmed, then nobody minds you cancelling stuff because they're not going to get any more money for it. But when it's on one of the different systems, then you spend 3 hours waiting for authorization that you can cancel stuff to do the list, the cases you want to do, having lost those 3 hours of operating time. So the payment system that you have and is that in effect really can affect your day-to-day experiences in medicine. So block contract, so fixed payment, used for things that are difficult to measure, but it's not good for either party because if you under-deliver, then fine, you made some money, but the commissioners have not got good value. If you over-deliver, you don't get any more money, so you're not delivering good value, but the commissioners are great. So it has its uses, but it's not great. So capitation, that's how ICBs get their money. So capitation is basically a per capita, per person payment. The controversy, I guess, or the variation is how you adjust that population to factor in complexity. So how much weighting do you give deprivation? How much weighting do you give rurality? How much weighting do you give kind of age differences? That's where people are kind of having discussions. So that's how health boards in Scotland, Wales, and Northern Ireland get paid. That's how our ICBs get paid. It's also how the bulk of the standard GP contract is funded by this Cahill formula, which is basically how many people in your population. You adjust that population based on various factors, and you get that's how much you get per person. But as I say, it's the weighting that's the key. So pathway of care, it comes in and out of fashion. It was at one point it was going to be everywhere, but they've decided that that actually it doesn't work very well. So pathway care when it was used historically in maternity services, it doesn't anymore. You got one payment for antenatal, which had 3 levels. One payment for kind of the birth, perinatal, intrapartum, which had 5 levels of complexity, and you had one payment for postnatal. And the problem was that once you started on one pathway, so say you were low risk pregnancy, you got your low risk payment. Then if you needed another 10 scans, you didn't get any more money, and you didn't go up the kind of risk kind of payment system until you became intrapartum. So it wasn't flexible enough, really, for most people, because things change. It was going to be used for things like joint replacement. So you got a payment, you got a overarching lead provider that can subcontract different aspects of that pathway to different people, different organisations. So your physio, your rehab can all be subcontracted out if needed. but it's used in some parts of the world, currently not here. Going back to that question that they've got, so yes, comorbidity and deprivation is factored in. It's just how it's weighted. So the controversy between both in terms of the Cahill formula, which is what is used for the GPs, and for ICB funding, is that how much should you factor in deprivation? Comorbidity is very hard to measure, so probably not used, but deprivation and age and socioeconomics generally, and what the best measure to use for that is controversial in terms of nobody knows how much deprivation really does affect healthcare spending and costs, and how much age, how much of an issue. So we know that it does affect it. We know that deprivation affects health access and health inequalities. We know that age changes. The extremes of age are the most expensive times of general for most people. But what we don't know is how much weight you need to put to that. And so that's where the controversy is. Pay performance is part of most contracts. In GP, it's called the Quality and Outcomes Framework. There used to be a component called Sequins, or Commissioning for Quality Innovation, which are used in acute community mental health. Now that's on pause, and you've got something called best practice tariffs, which I'll talk about later. But basically, when you get you get one tariff if you just deliver standard care. If you meet certain criteria, you get more money, essentially. So that's your performance-based or quality-based component to your funding. For GPs, under the standard contract, GMS contract, it can be up to 20% of your income can be from as a performance-based metric. Per diem is not really used in this country. It's a per person, per patient, per day of care payment. It's used a lot in some other parts of the world, particularly in the less economically developed countries. And the one that is probably the most common is this case-based or activity-based reimbursement. So the more activity you do, the more money you get. It's you factor in three components really: any diagnosis, any treatments or operations, and patient characteristics or comorbidities. They get put into a software program, and they come up with what's called an HRG, healthcare resource group. And generally there's a tariff based on each healthcare resource group. It's used in the acute sector. It's not. They tried doing it in mental health services with clustering, but it didn't really work. So payments aren't based on tariff is not based on clustering in the mental health system. They're based on block contract. Okay, and pass-through payments are basically where, for really expensive things, really specialist things like high-cost chemotherapy drugs or specialist services, where whatever it costs you to deliver that service is what the commissioning body will pay. So yeah, that kind of 7 components. Pros and cons of each one. Most payment systems use a combination. So when we had everything was case-based, was that payment by results we'll talk about. Great for bringing down waiting lists, not so great for emergency care, because emergency care is so variable. You can't, or you will always lose money on it. So what they've done at the moment is something called an aligned payment incentive, because during block contracts, we did no elective work and the waiting list grew. If you make everything activity-based, then the emergency care basically loses money and you get different problems. So what they're trying to do is cover the emergency component on a block contract, so the fixed element. So you agree how much your emergency costs are, and for things that are difficult to measure, like mental health and community and ambulance services, they only have a fixed element. They don't really have a variable element. But this means that everybody can be on one contract, one type of contract at least. It's just they have no variable element. So the fixed element is basically a block component, and it includes expected, so best practice tariff and sequence. So sequence is not a component anymore, but you include the fact that you're going to get the best practice tariff, and then if you don't get it, then it gets removed. CNST is your insurance premiums, essentially your clinical negligence scheme for trust premiums. Include all of that, and then the variable element is your elective works. The more activity you do, the more money you make. And that's to encourage people, organizations to bring down their waiting lists. Okay. So that is for almost all contracts, apart from what's called these low volume activity contracts. So they occur. So for example, in Leicester, we definitely get people from Kettering, Northampton. So our volume of activity will be more than £500,000. But we're unlikely to get people from, Northumberland. So we won't. So if a patient comes down from there, that'll be on a low volume activity contract. So it'll be a kind of a per person thing. In similar ways, Cornwall might have a contract with London because so many people have second homes over there, but they may not have a contract with people in the Lake District. So it's about what your volume and likelihood of people coming down is. Okay. Final bit, which is about GP practice funding. I'll play it. I won't play all of it. I'll play a portion of it, and then we'll have a break.
Welcome to my bank. Yes, Revolut is a bank.
This animation gives an overview of how general practice is funded in the NHS in England. In the NHS, general practice is usually the first point of contact for people seeking advice and is the gateway to healthcare delivery. There are over 1.3 million GP consultations every day provided free at the point of delivery, taking place in GP surgeries, within the patient's home and, increasingly, online. There is no standard model for how general practice should be organised. GP practices come in many shapes and sizes to suit the needs of the local community. There are single-handed GPs, multi-partner practices operating across localities, and super practices covering much larger geographical areas. The common factor behind each general practice business model is that most of the individual GPs and practice staff are not directly employed by the NHS. General practice has always been an integral part of the NHS family. However, each practice is a standalone business, with a partnership or corporate structure, providing specified healthcare services on a contractual basis to the NHS. How is general practice paid for? The flexible structure of general practice was established in 1948 with the creation of the NHS. The funding mechanisms have evolved to meet the needs of the NHS as we know it today. There are two types of contract used to commission general practice services. The most used is the General Medical Services Contract, which is nationally negotiated between NHS England and GP trade union representatives. It states the core services that a GP practice must provide to people who are registered with the practice. The total funding for all registered patients, called the global sum, pays for the core services and is determined by the NHS annually as part of the national allocation process determined by Parliament. Each practice receives its weighted population share of the global sum based on its registered list size. The process, known as the Carr-Hill formula, assesses the funding required based on the workload drivers, such as demographics and list turnover, and costs drivers, such as geographical price factors and population density. In 2022 to 23, the annual weighted population payment was £99.70 per patient. This is paid to the practice monthly and adjusted quarterly to account for fluctuations in the registered list of patients. In many parts of the country, GP practices have opted out of providing some core services. For example, many practices do not provide out-of-hours services and transfer the responsibility and part of the funding, currently 4.75% of the core funding, to separate out-of-hours providers. The other contract type is the Alternate Provider Medical Services Contract, APMS. It is a more flexible contract that non-GP organisations can hold. For example, private, third sector organisations or NHS trusts, and can be used to commission specific services outside of the core contract. For example, services for the homeless or asylum seekers. In 2004, the NHS introduced the Quality and Outcomes Framework to incentivise general practice to adopt good practices and focus the practice's efforts on local and national clinical priorities. The framework uses a system where points are awarded for the delivery of specified activity relating to specified domains, clinical services, public health and quality improvement. Each year, a practice can achieve up to a designated number of points and receives an additional payment based on their weighted registered patient list. In 2022 to 23, for the average-sized practice with 9,374 patients, there were 635 points available, and payment for each point was £207.56. General practices have the option to provide services for their patients that go beyond the basic core services. These are known as enhanced services and can be defined at a local or national level to deliver services to registered patients, such as vaccination or weight management programmes. The NHS amends the range and scope of enhanced services each year to deliver current service priorities. In 2019, General Practice created primary care networks using the Enhanced Services Funding Agreement, and these networks continue to expand and develop. Primary care networks are groups of GP practices working closely together, with other healthcare staff and organisations providing integrated services for registered populations of between 30,000 to 50,000. Practices often work through GP federations and increasingly primary care networks to provide other services closer to where people live. For example, by providing a minor injuries clinic to relieve pressure on the local A&E department and near-patient testing to reduce the number of hospital visits. Contracts and funding are negotiated locally directly with practices involved and can be based on price per activity or annual block payments depending on the treatment. In addition to the cost of providing clinical services, there are many other costs relating to running a GP practice. Practices are assessed and reimbursed wholly or partly for many of these costs, including those related to property, IT, locum fees, inspection fees and clinical waste disposal. In summary, general practice is organised to meet the local needs of a geographical area. The funding models have been developed to support the working arrangements and provide sufficient flexibility to allow different structures to coexist within a common framework, whilst ensuring consistent and high-quality services are available across the country, irrespective of location.
Okay, so any questions on any of that? So there's a almost an inbuilt check system. So primary care networks exist, and you'll find that in some areas, one company or one GP collaborative almost controls the whole primary care network. So whilst GP practice may have huge lists, you really need to have enough staffing to be able to deliver their care, because if they can't meet there are other KPIs, there are other key performance indicators such as proportion of same-day appointments available, how long patients have to wait. There are other important metrics that these GP practices have to kind of fulfill to make sure they, as part of their contract. And that's in particular with the APMS contracts, which is the kind of the ones that are not to the individual GP, but are the but to the company essentially. Yeah, so that's I mean, there's two components to this. There's funding and money, which is based on a block funding, but also there's your other metrics that mean so with most organizations now, whether you're a provider, kind of a NHS trust or NHS Foundation trust, you are still under the remit and control of the kind of main ministry, Department of Health / NHS England team. And so if you'll see that you have the provider assessment frameworks, which are different levels. So if you are, it's basically loads of league tables, but there are links to outcomes in terms of mortality figures. So you have various hospital-related mortality and other things. You have various other performance indicators, which then determine whether you'd like to get the contract or not, or how much input you get, external input, i.e. from NHS England / Department of Health, people coming in, and in the same way they can fire the chief exec, because if they feel that they are not doing a good job. So there are built-in kind of measures to try and maintain quality outcomes and productivity, particularly at the moment. But this is purely about how the funding is linked. So it's two different ways. This is, whilst we're trying to look at it in isolation, it's never really in isolation. There are lots of other components to it, if that makes sense. So it depends. If it's things like drugs and alcohol services, which are often provided by third sector organisations, they are put out to tender, and they are generally, if it's a non-NHS service, they will have been put out to tender. Different organisations bidded for them, and the funding is agreed. For things like drugs and alcohol, it would be a block contract. For things like waiting lists, reduction things, it will be on an activity base. So it'll be still based on one of those metrics, those kind of payment systems. It just depends on which one. It will depend on the type of work it does. So if and sometimes it's the provider organisation that outsources the work they can't do to these kind of private organisations. So that's how it's generally organised. It depends on the kind of work they do. Any kind of true elective care, where it will be done on a activity-based thing. If it's things like drug and alcohol services, which is providing a kind of baseline level of care, it will be on a block contract, again with built-in performance indicators and metrics, and things that mean that the contract can get taken away from them, at 2 years or 3 years, if it's depending on how long the contract is. Okay. I think we should take a break. I'll say 10 minutes. I'll be here for probably 5 minutes and probably the last 2 minutes if you have any more questions, but I suggest people stand up, have a walk around. I am aiming to finish this as close to 12 as possible. It might rhyme, and it officially runs to 12:30. But I will continue answering questions. Another 5 minutes, I'll go and make a coffee and then come back and finish answering any other questions that are there. Hybrid models of payment. I mean, that's basically what the aligned incentive payment incentive model is. It's basically a hybrid. It is a block based with a top up for activity. So your block contracts covers anything that's not elective activity. So which is basically your emergency care, maternity care, all that kind of stuff, and then your elective kind of care, anything that brings down waiting lists, essentially is activity done based. So you get, you know, some, that is a hybrid model. Even in places that only do outpatients and don't have emergency care, things like second appointments, follow-up appointments for outpatients, they're not proactive. You get very little money for those. You lose money on those. I'll come back to Martha's question, but emergency care, but basically it all comes down to that tariff system. The tariff system doesn't really work for emergency care. So same day emergency care it might work for, because it's fixed. You know, if somebody comes in, has something done and goes home the same day, that's fine. But a laparotomy can go home the next day or can be in a hospital for 6 months. You know, it's very difficult to get a tariff that will cover the full breadth of that cost. And that's what they found, is that with emergency care, the HRGs weren't, even though there are thousands and thousands of them, they still didn't cover the breadth of variation that you got with emergency care. They are looking at how to incentivize emergency care, because again, like you said, at the moment, I know I feel it all the time, where you struggle to fight the priority, you know, the elective work prioritization process. So they are working on it. They know that's a problem, but at the same time, the current government priority is driving down those waiting lists. So that's the situation we're on. So it's all about, you know, what the government wants to prioritize as to what then the payment model looks like. Why would trust ICBs allowed to overspend? It's basically all about planning. So you predict what your activity is going to be, but you can't. It's very hard, particularly for the acute sector, who tended to be the people that overspent. So the community and mental health trusts got fixed amounts, so they on block contracts, and 9 times out of 10, community mental health trusts either broke even or made a slight profit. It was and the specialist hospitals. So you've got some trusts, like in London, for example, Guy's Tommy's own half the area around them. They literally get income from all rental from multiple places. They get a massive private income stream, international patients for that. So they get a lot of money for them. But most other acutes essentially lose money, because, you know, we predict that we're going to get to a point where we're £2 million over budget. But for whatever reason, you know, staffing issues, the drive to increase productivity, you know, you have this balance between driving down waiting lists and being financially stable. Because you know, theatres, I'll use theatres as an example. Theatres operations are a big component of elective care, as well as diagnostics. We haven't got enough surgeons and anaesthetists staff, so we have to pay them more to work weekends, to work extra shifts. So that means that that's above our predicted amount of work, but they want to reduce our 62-week waits, 52-week waits, whatever it is, whatever the current target is. And and so we might have planned on not on having maybe 1% or 2% of premium pay, but we end up, because we really want to drive this waiting list down, 10% paid, or we've got more higher levels of sickness this year than we planned, than we anticipated for whatever reason. We've got the resident doctor strikes, obviously are unplanned. There were the previous set of strikes were they funded them, they gave extra funding, but these last rounds of strikes didn't get extra funding. So then, paying consultants to act down is an unanticipated cost. So that means that that cost comes in. Increases in medical spending. So if there's shortages of one drug because of there was a shortage of a few drugs recently, and so they've had to import things from abroad at higher costs. All of those are unanticipated. So that's why we've not been able to reach our planned, even if it was a £2 million overspend, we're £10 million overspend last year for various factors. So it's not that it's not necessarily that they're underfunded. It's just that, so as I said, the governments are much more concerned with accurate planning rather than necessarily breaking even, because they know that if you were £10 million over last year and they reduce the budget, or they want you to make a cost improvement program, you're not going to suddenly become break even, but they want you to be heading in the direction and achieve what you think you're going to achieve, anticipate. Health inflation. I think it's so variable. So they're trying to do this kind of reducing unwarranted variability. They're trying to purchase in bulk to utilize that, essentially try and get bulk buy discounts. They've also already negotiated with various companies, drug companies, to get certain drugs at lower than market value. But these quirks where you got sudden increases because of changes in we had that bone cement thing because the company shut down for 2 months to do some refurbishment work. That it's very difficult to measure that as part of health inflation. It was just a temporary thing that we had to go source some alternative cements. It's really hard to then factor in all the different components, because you've got health inflation based on wage rises, and that is measured. So the Health Foundation, King's Fund, all those kind of people will measure that. The standard stuff, it's the unknowns of healthcare cost increases that we don't really know what the impact of oil price changes and availability of certain components and products will be in the future. So all those things are it's really hard to kind of factor that in and measure, because there's so many variables. I think that's main issue. I'll give people a couple more minutes to before we start again. Okay. I hope you managed to stretch your legs a little bit at least. Going to try and cover a little bit about costing and clinical coding. Again, I apologize, the focus will be on the acute sector for this particular area because that's the area that's most developed in. It's not to say that it doesn't happen in other areas, it's just it's harder to do. So I guess the first question is, do you understand the difference between the cost and the price of something? So we use the words cost and price often interchangeably, but they mean different things. Okay, yeah, kind of. So, in very simple terms, I'm a simple man. The cost is essentially the amount spent by a provider or by a shop or by a company to make something. So it's basically how much it costs them to deliver an activity. Okay, whereas the price is how much you get paid for it. So the income. Okay, so that's the price of something in this context. Okay, so if you're somebody that in a shop or a manufacturer, you want to make sure that it costs you X amount of money to make something. You put on a bit of the profit, and you sell it for a different price. So that's the problem being that the price is set by the consumer in this case, or the commissioner in this case. Yeah. So the thing you have the biggest control over is your cost. Okay. Now, this is where it gets a bit more complicated. Tariffs. So the national tariff is set every year, and it's based on something called the National Cost Collection. So every year, every organisation, provider organisation, in the NHS, not the private sector, but in the provider organisations, submit how much it costs them to provide different services. Based on HRGs, essentially, based on these healthcare resource groups. So how much it costs them, for example, to do a laparoscopic appendix in a person over 18 years old with a comorbidity index of 0 and or 0 to 1, and then there'll be how much it costs them to do a appendix in a person over 18 with a comorbidity index of 2 to 4 or whatever it is. So there are different HRGs, and the providers submit a cost. And basically what the Department of Health / NHS England do is they take an average of that cost. They factor in health inflation, so any noticeable changes, so increase in staffing costs, increase in general inflation, and anything else. okay, that they think is important and needs factoring in. And they put an efficiency factor in, because they want people to try and reduce the cost of doing stuff. So they increase it by X amount and then reduce it by and a small amount as well. And that's the tariff that's how the tariff is set. Your income as a provider then is then adjusted. So each individual organisation has something called a market forces factor, which basically means that they understand that in London the cost of things are the slides aren't changing yet. I haven't changed slides yet. The cost of things are different to say in Birmingham, but also in Cornwall, because delivery and Northumbria delivery is harder, so actually they cost more, things will cost more there then. So they might have a slight, and it is a small adjustment. It's somewhere between 0.8 and 1.2 essentially multiplication factor, this market forces factor. And that's how your tariff is set. Okay. What you then need to do, and what the problem has been, is that we've never really had accurate ways of determining how much it costs us to deliver a bit of care. Okay. And but we are trying to get that shortly, and we'll talk about that in a second. So we are trying to get more robust and detailed analysis of how that costs are. But our income, that HRG thing, we are really bad at. We generally, particularly in the acute sector, are really bad at making sure that that coding component, because that's where the HRG comes from. It comes from what's documented in the notes, which then gets coded and determines the HRG, is where it causes problems. So again, as much to stop you having to listen to me the whole time and somebody else's voice, a little animation. These are all available on YouTube to watch back if you wish.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge. Coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Okay. Okay. Any questions on coding? Because it's a topic that we probably don't get taught enough about, but has a massive impact on what we do and how we and our income. There have been lots of initiatives to try and change that. So most, depending on whether you're on an EPR, electronic patient record, or whether you're still on paper, EPRs are helping. But they haven't quite matched the terminology that we use and the language that we use on our documentation with the coding rules. So in mental health, they diagnose and put things in pretty much according to ICD-10. Actually, use ICD-11, but the coding system still uses ICD-10. Autonomous coding, it will come, it's just not there yet. And there's two reasons for that. One is that we still write a lot of free text. They're trying to stop that in most of the EPRs, but most of the EPRs are built with the ability to write quite a lot of detail in free text. And we still document on EPRs how we document in the notes, which doesn't allow for that autonomous coding component. What they are trying to do is increasingly build fields that are just got labels on, so specific diagnosis fields and comorbidities fields, which use a specific terminology system called SNOMED, which is similar to how we generally speak in using medical terminology. So that's more, it's closer to how we do our documentation, SNOMED CT. SNOMED clinical terminology is what that stands for. And then once they've done that, they can match things across. So the clinical coders know that at some point there will be more having a quality assurance role rather than actually doing the coding role. But we are probably 2 or 3 iterations of EPRs away from that. So some places have tried that. So I think it's Rotherham have got some sort of system where they've got some system where the EPR captures and they've matched the coding terms and what's in on the EPR. But a lot of the big issues are related to how those are how the EPR have been built. So they've been built as free text fields rather than as specific label fields for them to be able to do anything with it. And that's why we find it hard to get good accurate data for our QI projects from the EPRs, is because it's how it's all been built and labeled. They've been built for one purpose, the user interactions, rather than for the back-end purposes. But that will come. It is already coming, and some places have already started doing it or trying to do it. It's not there yet. The key things are to make sure that you document clearly and comprehensively, both for funding but also for medical legal purposes. Okay, so costing is about finding out where that money is being spent. So it's whether it's on staffing, whether it's on activity, so inpatient care, surgical procedures, or pathology tests, you then try and put that all together down to the patient level. So that's what patient level costing is all about. It's about trying to get detailed analysis down to the patient level of where all the costs are. So what you try and do is you try and get, you factor in your kind of general costs and you split them up equally. So your HR, IT, finance staff, your admin staff, all that kind of stuff gets kind of just generally split up. And then you get your kind of actual costs of delivering the patient care, so the award costs, and essentially because it's very hard to capture how many interactions that a patient may get from staff, you basically, the easiest ways to do it is to do the number of minutes on a ward times the level of acuity. So you get level 0, which is most wards, level 1, which is slightly more intensive or high dependency, kind of slightly enhanced care wards, level 2, which is high dependency units, and level 3, which is intensive care. So you can do that. Theatre costs, you can just put the staff costs and then divide them up by how many minutes they're in theatre. There are better ways of doing that, but that's generally how it's done at the moment. Radiology costs are actually quite easy. The actual other 3, drug costs, pathology costs, and radiology costs, are actually far easier to do because they're more defined and distinct. PLIX is much more accurate for surgical processes because it's a bit more like it's more distinct and more measurable than medical or mental health or any other area. They're still developing mental health costing, and that's why clustering was very difficult, because they didn't have enough. There's too much variation in how much it costs to deal with a schizophrenic. Somebody with schizophrenia can be quite severe. They might have other issues, might have physical health issues, and so it's very difficult to then put it all into one cost. But that's what they're trying to do at the moment. So then you can either divide up how much your cost. You can then look at it by hospital, by site, by clinician, by HRG, and it's a good source of data for any QI and business cases. So for staffing, say you have a consultant, and Easties are very easy. We have we're very sessional, so we just divide up our sessions up. But for, say, medical staff, or depending on whether they do ward rounds, whether they do kind of any cardiologist, whether you're in cath lab, whether you're gastroenterologist doing the scope lists, whether you do MDTs, whether you do outpatients, you divide up your kind of time accordingly, and then that gets divided up to the number of patients, number of meetings, and you divide up that cost appropriately. Yeah. So again, you can then get an idea of where the costs are going. It's not it's clear. I know most of my, I mean, as I said, anaesthetists are very easy, but surgeons, medics, they often do ward round, then go to theatre, or they do something and then do something else. They do multiple things at the same time. It's not completely reflective of actual practice, but it's a start. But what you can do is then use it to help with operational service redesign, reconfiguration, business cases. You can find out where the problems are. You can identify clinical coding errors or issues, case mix issues. You can even benchmark yourself against other organisations. And this is the Acute Plex portal, which is something that's available by NHS England. And it compares, the submitted costs for all different procedures, and you can see where you are in that. You can do it, for example, you can do it to optimize pathway. You can justify a pathway change. So what they did is they used it to review 2 procedures. So your standard TURP, and then this new concept called Eurolift. And on the face of it, Eurolift is more expensive, but actually, because they were quicker, because it's quicker to do, does it as a day case, so you don't have an overnight stay or a couple of days stay, which is what you did with the TURP. It was actually overall cheaper. So that's where PLITs can be really useful. Another one they did in Leeds was they determined that they looked at cath lab data, and they saw that 10% of all standard angiograms were taking longer, and therefore then costing more. And it turned out that there was a documentation issue where they weren't actual standard angiograms. They used a different bit of kit and should have been coded differently or documented differently. And so they changed and managed to both reduce their costs, but also factor in that increase their income. That's a little bit. But more importantly, they could then show that they were doing a higher complexity cases. So you can use that for various purposes. Right. So business cases. So this is where we try and bring it all together. So what we're going to do is every organization has a different business case pathway. So they have different ways of authorizing and approving business cases. But the principles underpinning all of that are the same. So that's what we're going to talk about. We're going to talk about the process that's been described by the Treasury for all public sector business cases. There are whole courses devoted to writing public sector business cases. It's called Better Business Cases, but they are for multi-million-pound business cases, which we don't tend to do. Okay, so we're looking at adapting that process for healthcare business cases, and that's what this bit of the talk is going to be. So what is a business case? So there are 2 parts to a business case, or two reasons for a business case, okay, or 2 purposes is probably a better word. One is it's basically your pitch. It's we said there's a finite amount of money. Why should and most business cases, I say most, are generally good ideas. They're generally sound ideas. They're not always the best option, but they're sound ideas. But what you're trying to do is, why should they fund you rather than somebody else's business case in this round? Okay, so why do you need funding now? So that's the first bit. The second bit, and it's not as important, but it's quite an important setting that's often overlooked. It is a document of your decision-making process, why you've chosen this particular solution to whatever the problem is that you're trying to address. Okay. One of the biggest issues I see with business cases, so I look at business cases, I review business cases. One of the things that I've offered to people around the country is that it's very easy to tell when a business case has been written with an answer in mind, with a solution in mind. So you've got an idea of what you want to do, and you write the business case based around that idea. And if you do that, your business case is more likely to be not successful. Okay, so what you need to work out is, what is the driver behind your business case? And most of the time, the best business cases, you have to solve a problem. You have to show there's a problem, and this is the solution you've chosen to solve that problem. And if you go in trying to solve a problem, you tend to address a much wider range of options, and you have a much more coherent pathway, decision-making process to come up with your solution. If you go in with a solution in mind, you write everything based around that solution, and then all the other options are very unthought. They're just not very well thought through, and often it gets picked apart. What I will say is that when we are writing business cases, or whenever you're writing a business case or your team are writing business cases, you know everything about your business case. You know it to the nth detail. Why things will work, why things won't work. A lot of the people looking at business cases are either not clinicians, and a lot of them are certainly not experts in your field. So you'll find that they will not be able to understand all the quirks that you've dismissed, all the things that you've dismissed because out of hand, they may not realize. Okay. So it's very important that you think about what the problem is that you're trying to prove. Okay, you're trying to solve. Occasionally, you might be able to get a business case through if you're just improving quality. If you're showing that improves quality to a significant level. Okay. So if it's cutting edge technology and you're showing that that's what you're going to do, and it's going to bring this so much benefit to your organization, then you might be able to do it that way. But most of the time, it's solving a problem. Okay. Know your process. Know who you're pitching it to. Okay. Know what hoops you've got to jump through, which committees you need to go through. And that kind of depends on how big your ask is. So you need to have an idea relatively early on of what scale you're asking for. Are you asking for something that's going to need approval at NHS England / Department of Health level, or is it just within your CMG or directorate, or is it just at your organisation level? So what level are you looking at? Are you pitching at the right people? Is this going to, are you pitching it at your commission, at your organisation? Should you be better off pitching it to the commissioners? Is it that there's actually a national pot of money available that you might be able to apply for? Is it better to go for education funding? You might have to slightly pivot your business case if you want to if you think that's a better route. And so just think about the process, who you're going to pitch it to, because you might find that your standard way of doing it is not the right way, and actually pivoting slightly to get a most common thing for us is trying to get from educational funding or from national funding. Okay, so just think about that. So in a business case, you want all the kind of who, what, where, why. Okay, but we want it in a structured, coherent way. So that's why we're going to use something called the 5-case model. Okay. There's something called the strategic case, which will go into a lot of detail. The economic case, which will go into a fair amount of detail. The commercial and financial case, you need to get advice on. We'll touch on it. I'll give you some tips, but essentially they are the specialist stuff that your procurement and finance teams probably need to be involved with, okay, to give you the best advice, because it's so variable across the country. And the management case, which is again, we'll focus on a little bit, but again, your operations teams probably need to be involved in that. So most of the time as clinicians, the bit that we're involved with most is strategic and economic case. So that's the bit we're going to focus on. Okay, the other three we'll touch on, and we'll kind of touch on what should be done about it, but it is the bits that you need extra help with. So I'm going to come back to that in a second. Strategic case. Okay, so the first thing you need to do is work out how this fits into your organization's grand plan and priorities. So if you have a a business case, okay, so you need to work out what your organisation. So currently, my organisation's priorities are about reducing waiting lists essentially, because that's a national priority, and being financially stable. Okay, so when you in your first couple of paragraphs of your business case, you need to work out how what you're asking for is going to fit that plan, because that's what they're going to prioritize. If they see that it's going to fit in with their plan, it's going to go up the ladder, up the the priority list in terms of importance and likelihood of succeeding. Okay, so how does it align to the organization's aims and ambitions? Put that really early. What is the context that you're going to put it in? How does it fit with the organizational strategy? Your first couple of paragraphs need to have that in it, because otherwise that's where you're going to get buy-in. If they go, actually, this is going to work for us, they're going to keep reading, okay, and read it in more detail than just skim it. The next bit you need to do is work out what the case for change is. So this is where you have to show there's a problem. Show that that's what you're doing, why this needs to be addressed sooner rather than later. Okay. And what I'll say is that the stuff that gives you the least amount of kind of prioritization is Royal College recommendations. Okay, because there are X number of Royal Colleges, and they produce both NICE and the Royal Colleges. They are things that will happen, and you can say, this will happen, but they don't have any very few Royal College recommendations are you have to do this right now. It's an absolute mandated. They are things that this is what you should be doing, and you can work towards it, but this is the preferred option. So it doesn't actually add as much gravitas as you would hope. So it's the other stuff that are a bit more important. So benchmarking yourself against other hospitals is important. CQC reports, very important. So if the CQC said something, then that will automatically put up the prioritization list. If it's had problems with it, if you've got mortality reviews, again, that's quite useful. The model health system, so it used to be called model hospital, model health system, can be quite useful, again, for benchmarking. And so is getting it right first time. Again, they all kind of fall under the benchmarking umbrella, really. But for example, so this is off the model health system. So this was about a anesthetic gas that called desflurane that we were one of the highest users of in the country. It's the main issue with this gas is it's really bad for the environment. It doesn't actually add that much benefit clinically, but it's really bad for the environment. So as you can see, lots of organizations have tried to get rid of it. I use this graph to show that we were really a high user of it to justify buying other bits of equipment, so syringe pumps, to try and use different forms of anesthetic techniques that you had the same benefits. And so this is a case where I applied for sustainability funding. So the ICB had a green budget, and I showed this to them, and we got some money, capital money, to buy some more pumps. So one-off spending, that was okay. But you can use the graph to show that it is a problem. We need to do something about it. Within within 6 to 8 months of taking on that role, we kind of eradicated it from our trust. So we no longer have any desflurane. So that's just one example. Another example, okay, so length of stay. So this is a model hospital, model health system graph. It's a few years old now, but it shows that, so ours is a black line, so the kind of quality metric that's being used here is a length of stay of 2 days for emergency appendicectomies. Okay. Ours is quite low. We're at the bottom end of the number of people that have a length of stay less than 2 days. So what I did was we used our PLIX data, and it basically confirmed what we knew, which was that the reason they have a length of stay of more than 2 days is not because our surgeons are particularly bad, it's just because we haven't got enough emergency capacity, and patients are waiting 2 days before they even got an operation. So you can use that to then build a business case to have extended operating hours, a second emergency theatre. So you can use it for various different purposes, depending on what your other data shows. But this is the kind of stuff that gives you good I say ammunition, but a good reason for showing the problems and highlighting the problems. And occasionally what you have to do is then, you have an idea, you know something not quite right, but you need the documented proof to show it. So that's where your QI projects come in. So you then use your QI projects to then build into and give weighting to your business cases. So that's how you transition from QI project to business cases. So you can go from one to the other and back again. Okay, so you know that there's a problem, use a QI project to illustrate the problem, and then you then put it into your business case. So the rest of the strategic case is all about documenting the situation. So what your current system is, what your current setup is, what the current situation is, okay, how things are going to change, what the current needs are currently, so what's the problem in terms of your demand, and then what your future demand might be. And you should factor in 2 or 3 years of demand change, because what you don't want to do is put a business case in now and then a year later go, oh yeah, things have changed again and we need another business case for the same kind of thing, for the same problem. That doesn't get looked on well. If you put a business case, it's got to last a good couple of years, 2 or 3 years, before you put another one in for the same kind of problem. Okay, so factor that in. Demand and capacity modeling is to do that. You have your potential scope. So what that means, and that links in with the spending objectives. So, what are you trying to do? Is your aim to build, how big is this business case going to be? Are you looking at building a whole new, theatre complex with more theatres, or is it just staffing into the evenings? And what is it you're looking for with this business case? What's your scope? Okay. And that kind of is determined by your constraints and dependencies. They're all kind of interlinked. So your constraints and dependencies, most of the time, for most people, constraints are infrastructure and estates. So even if you want to run a clinic, every week, do you have space? Is there space to run a clinic every week? Does it have to be every other week? Because actually there's no space to run it. So what's going to limit the scope of your project and what you can spend the money on? So that's what your constraints are. Your dependencies are where one business case is linked to another, or one process is linked to another. So it might be that one of the examples that we're going to use later on is they built a daycare centre, an orthopaedic daycare centre in, let's say, Oxford. And so you've got a business case to build this centre. And that business case included the kind of theatre staff and operating people. What it didn't include is a radiology backup. An orthopaedic centre, so orthopaedic, because it comes from different pots of money, radiology cover was a key thing. Okay, if you don't have the radiology cover, then you can't run the orthopaedic daycare centre. So the radiology business case was dependent. Oh no, the whole daycare centre business case was dependent on a successful radiology business case. They were interlinked. Okay. So that's where one is dependent on the other. So one process is dependent on another business case being successful. That's what constraints and dependencies are. Benefits and risks. So benefits are obviously what you hope will be a good thing. Risks are what might happen badly. There's another word that's used in this context. I don't like the word, but it is used. It's called disbenefits. And that's negative things that are bad that will happen, negative consequences, essentially. So the most common thing are things where it impacts. So, for example, we used to do a Dragon's Den style pitch sessions a few years ago, where people came and pitched their business cases, and a radiologist pitched a different way of doing a breast screening program, where they use injectable something or other dye and improve the sensitivity and specificity of the breast cancer screening program. But one of the negative things is it takes longer, so you see less patients. So that's a disbenefit. You see less patients, so your productivity, not your productivity, but your it has a negative impact on capacity. Okay, so unless you mitigate that by either having more sessions or extending your sessions, then that will look bad. So you've got to show that you've thought about this unintended consequence or this negative consequence and how you're going to mitigate it. So that's what's they use the word disbenefits, but essentially it's a negative consequence and how you're going to mitigate that. Because risks are things that might happen. The disbenefits are negative consequences that will happen. Okay. So demand and capacity modeling is just looking at previous activity and how things have changed, and then forecasting how things might change for the next couple of years. Okay, so you just look at your numbers and forecast a change. You look at, maybe it's useful to look at 2 years worth in the past to then factor in how your next 2 years of activity might change. As I say, what you don't want to do is have the same problem in a year because you haven't factored that in. This is a way of doing it. If depending on your payment system, so this is old data in terms of the prices, but what you can see is that you can then also potentially have a financial implication for increasing those things if the commissioners work. So it depends on the payment system. Okay. The economic case is about your options. And as I said, the long list is think about all the potential solutions, however broad, however unworkable that they might be, because otherwise what happens is you submit it and then the feedback is, what have you thought about this, that and the other? And you go, of course I have. They're non-starters. But if you write them down, then you can show that you've at least thought about them, so that some person that's not in your specialty or not a clinician doesn't then try and suggest it as an option. So think about all the different things. Your assessment criteria are essentially what you're going to judge it against. What are your requirements? And if you think about it as essential and desirable, that's probably a good way of doing it. With the essential criteria, your critical success factors. Okay. And then you get your long list down to your short list. And what you do with a short list is you have to have at least 3 or 4 options, really. Okay. And it must include a minimum or do nothing option, just so you can compare them. And then you do an economic appraisal, which is basically how much quality improvement are you going to get? So what's the level of quality improvement you're going to get? And then what's your ballpark costs for that, for each of those 4 options, just so you can compare them. Okay, so you can see, I can get a 20% increase for this cost, I can get a 30% increase in quality for this cost. So you have an idea of the level of improvement for the cost, so you can show where the value is. The shortlist is where people struggle. It's where people struggle to think of options other than what they have thought of originally. So what you can do is do a kind of options appraisal. And there's lots of different ways of doing options appraisals. This is just one that was suggested. Okay. And the example I use, because actually it's people tend to understand it most, is we're going to use HS2, the high-speed rail link. Okay. So the problem is there's not enough capacity on our rail networks, particularly between London and the rest of the country. Okay, so the scope is what you're going to do. So scope is, are we going to increase our capacity? So the minimum option is to increase the capacity between London and Birmingham. Okay, the maximum capacity is to increase our rail network capacity between London, Birmingham, the northeast. So Leeds and the northwest. So that's and then the intermediate is London, Birmingham, and just the northwest. Okay, so they're the 3 options. That's what we're going to do. That's a scope of of what we're going to do. So for my emergency theatre, it could either be running our 1 theatre into the evening. In the maximum would be having a whole new theatre complex, a whole new theatre. An intermediate would be running a couple of theatres into the evening. So you can have different scopes of practice. And these different points are independent. Okay, so they don't have to be necessarily linked. So the how is how you're going to do it. So the minimum option would be refurbish the tracks. The maximum option is to build new tracks. The intermediate option is a combination of 2. Okay, so you can do different things. You can do it different ways. Okay. So how, again, how are we going to do it? Who is in the context of the NHS, is it, how is it going to be run? Who's going to be running it? Is it going to be consultant-led? Is it going to be nurse specialist-led? Is it going to be nurse-led? Is it going to be allied healthcare professional-led? Or is it going to be an MDT? Who's going to be delivering the service? Okay. In the concept of HS2, it's is it going to be a local, national, international contractor to deliver the solution? Okay. The when is how you're going to implement it. Are you going to do it on a trial basis? Are you going to do it as a pilot project? Are you going to do it as a gradual phase rollout, or you can do it as a big bang rollout? For HS2, is it going to be we're going to do one at a time? So we're going to do London to Birmingham first, then do the next bit. Are we going to do all three simultaneously from the different starting points to meet in Birmingham, or are we going to do something in between that? So how it's going to be implemented. And funding is, where's the money coming from? Is it coming from commissioners? Is it coming from within your own directorate? Is it coming from external sources? Okay, so where's the funding coming from? Are you going to have cost savings related to it? Because that's where we already have the income, or is it generating new income? Okay, so think about where the funding is coming from. And then what you do is you've got your options, and you basically put this table in. You've put in red what are non-starters because they don't meet your criteria. You put in green your preferred options, and you kind of put in yellow your kind of they're possible but not your preferred, and you write why you've chosen what you've chosen. So that's a nice, simple and straightforward way of demonstrating that you thought about different options, and it gives you a short list of sorts to consider. So we've covered the is it needed, why do we need to change, the risks and benefits, and the quality case. So is it what's going to show the increase in quality? Is it value for money? Is that we're putting the qualitative appraisal with the cost appraisal? So is it value for money? Is it equate? What options have been considered? And then why you've chosen what you've chosen. So that's the bits that we get involved with the most. The procurement process can be varied. What you've got, if you're going to buy things, you've got to think about the whole life cost of something. So there are normally two components to equipment. There's the upfront costs, your capital costs, plus your kind of consumable costs. So every time you use it, you're going to have the bit of commit. You might have a consumable component to it. And which one works for you will determine how often you're using it. If you're using it all the time, and there's a big difference between the consumable costs, you might find actually paying a bit more upfront to have a lower consumable costs might be better off. If it's a backup emergency thing, then actually having a low upfront cost and a higher consumable cost because you're not using that option may work out cheaper. So, and what is the lifespan of the kit? Are you going to, there's no point signing a contract for 10 years where you're going to be stuck with something where something better is going to be coming around the corner. You're going to go, oh man, I wish I had that new bit of kit because that's actually much better, unless they build an automatic kind of upgrading system into the contract. So just think about that process. There are generally two ways to procure things. You can either go out for tender and then it's open, you put your specifications out and you kind of let people bid for it, or you kind of have a trial basis and you kind of test a few things out and you then do a direct award. Depends on the cost of things, but that's generally the two ways of doing it. Okay, but you have to talk to your procurement teams because procurement law is quite complicated. You tend to do the open tender for things where you know there's a wide range of people delivering very similar service, and actually you don't really have that much. You don't really care which one you use. You just want that service to be delivered. So we did that kind of thing for our interpretation and translation services. With the direct award, we trialed. So with our new anaesthetic machines, we were quite particular. It's the thing that people feel very passionate and particular about. So we trialed them, had various. We had each company came in. We had their machine in for a month. We tested them, and then we chose which one we thought was going to be the best. And then there's also the finance. We got it down to 2, and then the finances helped to determine which one we got. So procurement can be a complicated process. You need to get people involved in that. But look about the whole life cost. Personnel requirements are all about making sure that you kind of got the right number of people for what you're trying to deliver. So and it's about working time equivalent. So a consultant contract is based on a 42-week delivery, clinical care delivery. So if you want one extra clinic per month, one clinic every week, sorry, then you will need more than one working time equivalent consultant session, because actually 42, say a clinic is 1 PA, then you need 52 PAs rather than the 42 PAs that one consultant will be able to deliver because of leave and various things. So you just need to factor that in. An extra nurse on a ward 24/7 is like 4 or 5 working time equivalents, because they work a 37-hour week, 37.5-hour week. So you've got to work out, and HR tend to have good templates for what is required from each component. Contract issues are all about, well, if you already need a contract for a bit of kit, then it's very hard to then buy a similar bit of kit. If the company you're already contracted with already supplies that kit, you can't then go for a different bit of kit. You wait for the contract to expire and then put your kind of requirements into that contract issue. You also got kind of compatibility issues. So sometimes if your IT is supplied by one company, you can have some real issues. We've had real issues when we've bought a bit of kit with a different company's IT on it. So for example, like a lot of our computers are HP in our hospital, and a bit of kit. So one of our CPET exercise testing machines comes with a Dell computer built in, and that's taken about 6 to 8 weeks to make sure that it kind of can go into our the drivers and all that compatible to go into our hospital mainframe network. So you can have compatibility issues. Just think about if you're going to say have savings, how long is it going to be before you generate those savings? How are you going to deliver it? As I said, how are you going to implement it, and then what the impact on service delivery during that time is. Is it going to be a big bang rollout? Are you going to have the impact not only on your own service but on other services? So if you're transitioning from, I don't know, we had an issue where we were moving our renal transplant service from one site to another, so we had to ask a neighbouring hospital to cover our emergency transplants for 24 hours while we did that movement. If you're creating clinic that's going to, a specialist clinic that was previously being dealt with in a general clinic, does that mean there's more spaces in that general clinic? Or actually, are you reducing the impact, the spaces on that general clinic? What's the impact during while you're rolling it out? What's the impact if things go wrong? What's your contingency plans? If things don't go to plan, you can't roll it out. We have to delay it. Can you still deliver your service, or that kind of stuff? So engage your stakeholders, get all the people that are involved in it, because sometimes if you get enough people involved in it, supporting it, then you don't even need that good a business case. You just need written business case. If everybody's supporting it, you can get it put through without it taking too much hassle. But if they haven't been consulted on it, then they can then put more barriers in. The processes in the NHS can take a long time, and any delay because somebody put a barrier up can delay your business case by months. So get people involved. Anybody who might be affected in it, get them involved early so that they can be part of the process and they can support you, and then they'll champion your business case as well, and that tends to help. Some small tips. So small business cases, particularly if they're capital only. So if if you're buying bits of kit towards the end of the financial year, they tend to have slight surpluses that they need to spend, whether it's at your organizational ICB level. They're not big enough to do anything useful from their point of view with, so they tend to ask for, so that January, February time, tend to ask for anything that bits of kit you might want. For new services, they might actually say it's better if we commission it from the new financial year, but be aware that discussions can start in the previous November, depending on if it's a newly commissioned service. Think about, as I said, transformation funds, education funds. The difference between system and specialised funding will disappear, but at the moment there is still you got your system funding from your ICB and your specialised funding depending on who's going to benefit the most. And then finally, combined with a larger business case. So if you've got a small business case, then if you know there's a bigger business case that's relevant, you can't just tack on a random case. But if it's similar, then and useful, then you can put it onto a bigger business case that's more likely to get through. Education for, so we wanted an anaesthetic. So, for example, two things. So, if you want to refurbish a room that's primarily going to be used by resident doctors, then actually education funds would be better for that. If you want to buy kits or computers for resident doctors to use, education funds tend to better for that. But you have to then, you might have to. So we needed a hub. We lost our anaesthetic department per se as part of various reconfigurations, and we wanted an area for teaching and for meetings and for various things, and we wanted an anaesthetic hub, essentially a department. We couldn't get the funding from the estate's funds, so we pivoted and made it into a we moved our kind of registrar training rooms or registrar rooms and restrooms into that area. We've made one big room, which is we use for mostly for teaching, but it just means that our meetings have to be educational, or educational meetings get priority. So that's how we've spun it, so that it comes from an educational fund rather than from the estate's fund. So as long as you can, whether it's kit, whether it's refurbishment or things like that, they tend to do better from educational funds. There's obviously the things that can, bits of training equipment that can be used from educational funds rather than from main funds. So it depends on what you mean, what you need, and how you can portray it, or at least package it as something that's going to be useful from an educational point of view. So we've got a kind of a big screen TV and projection system, or not projection system, but a kind of conferencing system from educational funds, because we can use it for teachings, but actually one of the main reasons is for meetings and stuff like that as well. So, but that was packaged as an educational need. Okay, that is the end of the 2 and a bit set hours of teaching. I hope you found it useful. I'm happy to take any questions. I'll be on for another few minutes. You can email me any questions you have. If you have any questions. It is a whistle-stop tour. It is very much a overview. It doesn't go into specific your specialties or your areas. It is a kind of broad overview of how finance works in the NHS, how you can navigate it. The HFMA, Healthcare Finance Management Association, have kind of courses like online e-learning courses. They do some more fancier courses that require paying, but they do have a little kind of guide to healthcare, to NHS finance as well, which is, I think, is free. There's a small one that's free and a slightly bigger one that you can pay for. So there's various resources out there. The One NHS Finance website has an area where you've got links to various resources and glossaries and stuff like that. The slides will be sent out by email with a feedback form. Please feedback what you thought was good, what you thought was bad, what you thought we can improve on. So you get the slides and a copy of the recording via email in the next couple of days. That's it from me. As I said, hope you found it useful. Yeah, it's just a bit of attendance via the feedback form. If you don't email,
yeah, go ahead. Sorry, I'm just in a meeting. I'm just sure. No, you can go ahead.
Yeah, just email the the One NHS Finance team, and they can send you out your certificate of attendance. Okay. So feel free to email me any questions.